Am da, croeso i Dyfed Carel a'r
Well, good afternoon
tîm.
and
Dyma
welcome.
drydydd mewn
This is the
o
third in a series
cyfarfodydd
of
atebolrwydd
meetings of
cyhoeddus
accountability
ffyrddau iechyd ar draws
for health
Cymru.
boards across Wales.
Tîm o'r Llywodraeth Cymru gyda
This is the Welsh Government
o'r
team
Bwrdd Iechyd
meeting with the
Bwrdd Iechyd Betsi Cadwaladr
Betsi Cadwaladr Health Board,
wrth gwrs.
of course, and
Dwi'n i gan bod cynnifer ohono ni yma
since there's so many of us here,
i gyflwyno'n unan gall pawb esbonio pwy yw nhw pan maen nhw'n
could people, rather than going round the table, could people explain who they are when they speak?
cyfarfod yn cael ei ddarlledu
And this meeting, of course, is being broadcast
yn cael
and
gwylio
streamed, and
drafodaeth
so people can view the
Playback.
discussion.
yn Gymraeg neu'n Saesneg fel y maen nhw. Mae'r cyfarfod yn cael ei gyfieithu yn yr ystafell ac ar gyfer ein sydd yn gwylio.
Being translated as well for those of you watching online and for people in the meeting as well, so people can take part in both English and in Welsh. And the documentation has already been provided.
Mae amryw pethau sydd gyda ni
There are
heddi yn cael
many things,
ei honno. Felly mae pwyslais yn y drafodaeth heddi wrth gwrs ar bethau dyn ni'n
and
gofyn
the
am
emphasis is going to
sicrwydd
be
na fe'n honno'n dangos. Felly os yna byddwn ni'n cyfro pob elfen o'r
so that if we don't cover everything,
ni mae'r ddogfen yn ateb rhai cwestiynau gyda
the
ni.
documentation will certainly answer some of the questions raised.
Covering areas in relation to improving access to services, getting services ready for the future, the Health Board's approach to finance, and then finally questions in relation to how the Health Board is led and managed. Some of the items which we will touch on in the discussion today are ones which have been raised with me in correspondence from the public, so we were reflecting a number of issues raised in that context as well. As we go through each of the four areas in the agenda, it would be helpful that if somebody from the Health Board could give a brief statement at the start of the Health Board's position. I would be very grateful if that could be managed to 4 minutes. And please don't take it personally when I mention the fact that we've got to the 4-minute point, if at any point we do. It's really important that we allow enough time for there to be a full discussion as well. But before we go into the substantive 4 items, David, is there anything you'd like to make by way of opening remarks?
Yeah, diolch yn iawn. Gai just croeso.
Yes, thank you very much. I'd just like to extend a very warm welcome. And
Iawn, am y cyfarfod a dweud y gwir, o'n eisiau pwysleisio
regarding the meeting, I just wanted to emphasise
ddod at y gilydd fel hyn.
the importance of coming together like this.
Rhoi cyfle
It gives
gymeryd
an opportunity
fel bwr iechyd.
for us as a health board,
Wedi bod yn rhan o'r bwr am ryw 2 blynedd a hanner.
and having been a member of the board for 2.5 years.
Lot fai na hynny. Ond serth hynny, dwi'n meddwl bod
But despite that,
cyfle ar y cyd
I think meeting jointly
a ni a beth ni angen cyflawni i'r dyfodol.
helps us focus on what we need to achieve for the future.
Oedd iawn o waith ymgysylltu gyda
There's been some engagement work
mewn neuad a pentre,
with people in village halls and
gysylltu gyda gleifion, dyn ni ddim am gysylltu.
engagement with patients and
A chithau fel llywodraeth
you as a government.
ac yn ystod y cyfnod yna,
And during that period,
ac mae'n bwysig bod ni'n nodi'r llwyddiannau.
I think it's important that we note the successes in the implementation as well. And
Cerig na, mae'n
some of those milestones
angen i adeiladu.
that need to be built upon.
A dwi wedi cyfeirio mwy nag unwaith at
And I've referred more than once
the
to
ail-adeiladu
the rebuilding
iechyd mwyn sicrhau y llwyddiant.
health in order to ensure success.
A dwi eisiau pwysleisio
And I want to emphasise
partneriaid yna, dyn ni gyd yn deheu am yr un peth.
that of all these partners, we all strive and aspire for the same thing,
Ond dyn ni hefyd yn ymwybodol
but
i'r
also are very aware
llwyddiant angenrheidiol yn y mannau yna
of the necessary success in those areas
fwyaf yn
and where it's needed the most.
gwasanaeth lle mae'r cyhoedd yn dibynnu
We need a service where the public
nediad yn benna i wasanaethau.
have access to services,
Dyn ni'n ymwybodol iawn o hynny
and we're very aware
a ydy'r brifau sydd yn wynebu ni ar her
of the main things that face us and the challenges,
fys a gwasanaethau cancer.
in emergency services and cancer.
Galed, I geisio goresgyn.
Now we're working hard to try and overcome
and
respond to the challenges.
Yeah, da ni'n gweithio'n galed.
And we're working hard.
Ac mae'r cyfarfod yma heddiw
and this meeting today
yr holl dystiolaeth yn gyfle I ni, dwi'n meddwl.
And all the evidence is an opportunity for us, I think,
bod ni angen cefnogaeth ychwanegol
to see where we need additional support
lles ein staff
for the benefit of our staff
leifion.
and patients.
Chi ymateb I hynny eisoes a
And you've responded to that already.
I weld sut bydd hynny'n beth sy'n herne real.
And we see
Gyfle
how that will be implemented. It's an opportunity for us
a fel y meisydd yna sydd wedi profi
to build on these areas that have proven,
a gallwn ni trafod hynny dipyn bach mwy.
and we can discuss that a little bit more.
Dwi eisiau just gorffen
I would just like to conclude by saying,
Yn ystod y cyfnod, da ni wedi bod wrth I fel bwr iechyd, mae'n wir yn dweud
during this period we've been at it as a health board, it's true to say
o beth sydd angen. Yr anhawster da ni wedi cael mewn rhain,
that the difficulty we've had in some areas,
a sicrhau bod ni'n gwneud cynnydd. Da ni'n sefydliad sydd eisiau datblygu,
we are an organisation that wants to develop
to dysgu
and learn
yn fewn am ôl nhw'r wrth eraill.
from other health boards too.
Gyfnod rwan, dwi'n meddwl,
We're in a period now, I think,
da ni llinell mewn un
where we can draw a line.
Dyma beth da ni wedi cyflawni,
This is what we've achieved.
ond mae'r meisydd yna, mae rhaid I ni weithredu mewn ffyrdd.
But these other areas we have to act on in other ways.
Dwi'n bro I ddefnyddio term yna, lles sy'n staff, ac
And this is for the benefit of our staff and patients.
heddiw byddwch chi'n cael blas o hyn,
And today you'll get a taste
byddwch chi'n rhoi chydig bach o leini.
as we shed some light.
Diolch yn iawn.
Thank you.
Diolch yn fawr am hwnnw dyfyn. Byddwn ni'n sicr yn dod nôl I ambell o'r bethau chi wedi sôn am.
Thanks very much for all the things you've mentioned.
Agenda.
Lots on the agenda, of course.
Mynediad at wasanaethau.
Access to services.
As you just set out, the board, the executive team have been in place for just over 2.5 years. The early focus has been on governance, on leadership, on quality and safety. What I'm looking for by assurance in this discussion are indications of the board's approach towards its oversight of operational matters in the way that you just outlined in broad terms. As we will know, the board is, in terms of operational performance, plan care, a number of the other points that you mentioned, the worst performing health board, and that's been a consistent picture in cancer and planned care and in urgent and emergency. One of your local authorities recently discussed a health emergency, and there are significant challenges which the board is facing in relation to those areas. As you say, we've been in discussions in recent weeks based on your request, and I want to acknowledge the proactive approach which you've taken in relation to reaching out for additional support to engage with you on those items. We are keen to support you and the board in the work that you're doing. We've agreed with you, as you have alluded to, that we will deploy senior level support to work alongside you and colleagues to deliver those rapid improvements that we want to see in relation to cancer, planned, urgent and emergency. And it will be important that is collaborative work, and I'm sure that it will be. With that, by way of opening remarks on my part, would the board like to set out its view as to where it is in relation to improving access?
Yeah, absolutely. And I'll turn to Carol to begin with. The colleagues come in afterwards, I know, but Carol can help respond to that to begin with, I think. Carol.
Carol should be agreed.
I'm Carol, and
view of what the board is doing about improving access. The issue of timely access to services is the most significant area of improvement for the health board in the very short term. While significant improvements have been made, as you've referenced, across many areas since 2023, the core theme of feedback from citizens is access. very many citizens say to us that once they've accessed the service, they have high levels of satisfaction. However, the timeliness and the ease of access are the key priorities in improving safety and experience of citizens, and importantly, the care experience of our staff as well. So as a board, we are collectively clear that the challenges we face remain really significant. Demand continues to rise, resources are stretched, and inequalities persist. For some patients, accessing care is still too difficult, and we do not believe that that is acceptable. Behind every number, of course, and we'll be talking about numbers, I'm sure, is a person waiting for treatment, it's a family seeking reassurance for a member of staff, doing everything they can to support. When the health board was re-established in 2023, there were a significant number of issues of quality to be addressed, a very high number of prevention of future death notices that had been issued by His Majesty's coroners, and with three main themes: urgent and emergency care, the standard and timeliness of investigations, and the availability of electronic health records to aid safer patient care. Furthermore, Healthcare Inspectorate Wales had escalated from services to services requiring significant improvement. And 2 years on, the number of PFDs has dramatically reduced, with significant change in the processes and quality of investigation. And thanks to the Welsh Government for investment, a new electronic health record is being implemented in mental health. Both those services requiring significant improvement have been reassessed and de-escalated as a result. To address the actions that Cabinet Secretary, you and the issues you have identified in this meeting for the public, and we have as a health board launched a major change programme supported by funding provided by the Welsh Government in a number of areas. Planned care, cancer and diagnostics, and urgent and emergency care. 6 work streams of planned care focus on waiting list management, referral guidance, booking processes, pre-operative design, follow-up pathways, integrated planning. Weekend clinics have been introduced, delivering 2,500 additional appointments every weekend. Targeted initiatives for high volume procedures such as cataracts are being implemented alongside outsourcing and insourcing arrangements to increase surgical capacity. On cancer, dedicated teams are working to clear patient backlogs and numbers and improve performance against the 62-day cancer standard, and additional diagnostic capacity is being implemented. On urgent and emergency care, joint work with local authorities is critical, and you referenced the same in relation to Denbighshire. Together, we seek to address the significant issue of patients experiencing delayed pathways of care, supported by £30 million of investment across Wales, of which North Wales has benefited to strengthen winter resilience. And a system-wide approach is being adopted to reduce ambulance handover delays, improve triage and same-day emergency services. I just want to touch on other areas. Mental health. We've seen the introduction of 111 Press 2. We've seen improvements in CAMS, child and adolescent mental health standards. We've even seen improvement in mental health access, and that's been sustained. And on quality and experience, improvements in quality governance, including a new quality management system. Our progress is clear, our challenge even clearer. We shy away from that no more. We are absolutely committed as a health board, as we discussed in our September board, to place the key priority on urgent and emergency care, alongside, of course, some of those other areas that you mentioned, and we look forward to discussing that in further detail. Yeah.
I want to look at individual elements of planned and urgent emergency care, but can I start by asking you about this? So obviously, in order for you to have a handle on the performance across the various areas that we've already touched upon, having a grip on the data is critical in order for you to have the confidence that you will need as a board and to give us the confidence that we need as a government. In the most recent reporting for data, we know that the board is actually delivering the highest volume of in-sourced outpatient activity of any health board in Wales, which is a very, very positive. picture, but that the data which the board is reporting shows that there's been an increase rather than a decrease in the numbers waiting, which seems hard to explain. And as I understand it, we have still not resolved that question. So I'd like to understand what the board believes is happening there and what steps you plan to take to make sure that you have the governance in place and the grip on the numbers that you will need in order to be able to manage the improvement that you want to see.
Do you want to respond to that, begin with Carol?
Thank you very much indeed. Cabinet Secretary, you're referring to an issue that's come to light regarding the additional outpatients work that we've been undertaking. The aim is to provide, by the end of March, approximately 60,000 additional appointments to people in North Wales, and that is well underway. There would appear we are undertaking a review to get to the bottom of it and to be very clear about the errors that have happened, that there was a segment of that waiting list that was taken out for very practical reasons to manage the additional capacity, and whilst our weekly reporting was accurate, the monthly reporting did not reflect that. As a board and as a chief executive, I must have confidence in the ability of our data and the quality of data and the integrity of that, as was due as the government, I'm sure. We have commissioned a review that will take place to help us understand the integrity of our data and whether there are lessons to learn and where those lessons should be learned.
So do you have a sense at this point of what's going on, or is it, are you waiting to see what that review shows, and how quickly will that get you back on track?
So we know that with the outpatients initiative, we've already seen 17,000 people in the last 10 weeks. Yeah. We need to track back through to ensure that those 17,000 are reflective of the total waiting list, and that we can reconcile that appropriately. So we know the patients have been seen. We need to check whether the data has been updated and validated to reflect that.
Just before we move on to the individual elements, do you have a sense, do you have a concern about what that might mean for your broader approach to managing performance? You would just describe to me how you feel about that, because you're describing what appears to be an isolated issue here, but you surely can't really know that yet until you've done the review. So what's your approach as a board to understanding the overall performance in light of that? Yeah,
it's very helpful that I'm able to just demonstrate another example of where I think we need to really get into the data. So when I look at, we've looked at follow-ups, the number of people who are requesting, needing a follow-up. We have had a position where we have got duplicate records of people requiring follow-up. When you dig into that has resulted from having 3 different systems, IT systems in the organisation until the summer of 2023, when they were combined. It wasn't a full integration, a bit technical here, so apologies, but the data is pulling through. What we do know through our follow-up work is that there are a significant number of duplicates. So there's a lot of work to do to keep cleaning those lists so that we can have more confidence that every single patient on the list is requiring the care. We also have referrals from GPs, and they may decide to refer into a Ysbyty Gwynedd or Ysbyty Glan Clwyd, for example. We'll come on to this, I'm sure, in terms of the shape of the health board. So you can have the same patient requiring the same intervention on 2 lists, and we're joining those lists up to be absolutely certain it is one patient on one waiting list. So there is work to do. This is part of our development, and in terms of the support that you have offered, and we're very keen to do that. I anticipate that being one of the areas that we would like support on.
At the end of the day, the key thing is that the patients are being seen. So,
Indeed,
and what we want to make sure is that the data reflects what has been, for the board's performance in this area, very strong performance over the last couple of months.
To have confidence, we'll need to have confidence in the data.
Exactly.
So that incident means that I think we've got to then reflect and make sure we've got the confidence in the whole process, not just that one incident, as you say. Yeah.
So I want to ask you about planned care and cancer, and I'll ask Jacqueline to touch on emergency care with you. So obviously waiting times for patients have been improving. That's very much to be welcomed. But we're still in a position where over 5,000 patients are waiting 2 years, and there are still people waiting more than 3 years for treatments which none of us will be happy with. How is the board going to tackle that, and by when?
I'll you to on that, and then bring colleagues in.
Yes, thanks very much. So there's two areas that the board is particularly focused on: the here and now in-year delivery, and building and sustaining a system for the future. Both of those are important, because I'll just give you that example of where we have 3 different systems. In essence, this health board has not been a single health board. It's made up of 3 component parts. And that has been hampering our ability to really perform very effectively. So we've got to fix that. In the short term, the board has been overseeing an in-year programme of delivery across a range of areas, and different colleagues will comment on that if I may. Bring Bristol in on the 104 long waits and the cataracts.
Pan-Arbol, support Godwy, and cyfarwydd y Gathedral Bassett Dwi as well. So I'm the Executive Director of Finance. So really just to elaborate, so we have formed plans with all of our IHC colleague operational teams. We've mapped those plans across based on specialty, based on capacity and availability. And then we've managed that delivery across the year on a weekly cycle. So we've been seeing that working. Where we've also tried to add additionality has been on our contractual provision, so using providers, external providers. And what we found with seeking those contracts is we need to ensure that those patients are the appropriate patients to be seen and referred to our external partners, as well as ensuring we've got that commission profiles correct with those individuals. And there's a number of individuals who did not wish to travel, as we've alluded to earlier. So we've learned a lot of lessons around when we commission activity and commission additionality. The internal plans that we have, of course, we need to build on in terms of productivity and efficiencies, and we're modelling that through our major programme of home care work. We've set our trajectories for the remainder of the financial year, of course, and we've shared those with Welsh Government colleagues, and we'll still work with those to see where we can improve our position. And as you say, the reality is we are improving, and we're seeing those numbers reduce as we move forwards. It's the pace of that delivery that is the challenge for the health board. So we've significantly reduced from over 10,000 back in December, of course, and now we're about 4,600 just from our population base. So we've seen significant improvements, but that won't take us through. The other thing just to be mindful of, the other concern or challenge for us is, of course, we are seeing increasing numbers of patients becoming, obviously, as you move into January, there are more patients who become 104 weights. So the cohort of patients needing that treatment is rising, actually. So
that's a challenge for every health board. That's a common challenge in all parts of the system, which I would like to understand, if I may. Sorry for interrupting you. I want to get into some of the detail of this. So I understand what you're describing in terms of interventions, but the board is behind trajectory on some of the plans which it itself set out. So I'd like to understand what's your analysis of why that is the case. You mentioned patients not wanting to travel. That can't be a material part of it, I'm guessing, but if it is, you should say. But what's going on there?
So the original trajectories required a level of resource as well that we started off at the commencement of the year. So the original trajectories before required a level of investment. We haven't got that level of investment, so we're trying to work that through improved utilisation and population as we move forwards. And that has in some ways restricted the level of externals we can, or patients we can transfer out. And what we're trying to do therefore is work through a major programme of home care work in order to create more capacity internally for us to be able to see those patients, whilst at the same time trying to reprioritise resources as we go forward in order to try and create more resource that we can use to then effectively commission with partners and external providers.
Can I bring Galen in? Because he
could I say
well, you finance,
He's the vice chair as well as the chair of performance and finance. I think that the trajectories are set largely on, it's largely based on insourcing and outsourcing, which is not actually particularly satisfactory, obviously, in terms of the longer term change we need to achieve, but it's in terms of the speed of delivering results. And far be it from me to contradict you, Cabinet Secretary, but because you're absolutely right, obviously the idea of the tip-ins is absolutely core to every the health board struggle. But I don't know whether everybody always appreciates that. And as a lay person who haven't got the background in health, it took me a while for this penny to drop, that actually you can have 6,000 at the top of the quarter, you can have 5,000 at the end of the quarter, but you've actually seen 12,000 patients or whatever it is. So it's a significant overhang and legacy problem that we're dealing with. And as I said, directories are based principally on the internal provision of the health board matching what it has done traditionally, so it's not increasing its capacity, and then buying in extra capacity to help remove the backlog. So I think the answer to that is that in a sense, a lot of the underperformance, I'm not blaming the providers, but it's been about our procurement and management of those contracts, which is not to say we're ignoring the internal productivity, but I think those things are longer to deliver results. So I was quite shocked but I think Carol was quite shocked as somebody who's obviously been around the health service a lot longer than I was, at the number of things that were done that were probably well out of date. So I know you like to talk, but quite rightly, preoperative assessment. Everybody was physically invited to preoperative assessment, regardless of their condition. Which is obviously a huge waste of consultant resources. So we're addressing that. There wasn't sort of sufficient administrative and clinical validation. So people would wait for, perhaps 18 months and then see a consultant and be told, actually, this is not an appropriate course of treatment for yourself. We've started to address that. So those will yield pros in the longer term. And the thing I've become convinced about as somebody who perhaps started with a perhaps naive assumption that, it was all about not having enough resources. In revenue terms and in terms of routine planned care, I'm absolutely convinced that we do have the resources. We just have to be much more efficient in our processes. And we are on that, but seeing the fruits of that will take longer. So that comes back to Karen's point about, doing the immediate, trying to get into the backlog so we can start having the balance between demand and capacity, which actually I think is probably in most areas in balance, but that will only deliver real progress in the longer term, which is too long. And I understand why people are frustrated.
So my reading of what you're saying, if I could just summarise, there are a number of challenges which you're describing, which I understand are real, but they're common challenges. Yeah. The idea of getting to grips with the backlog is true in all parts of Wales, and the mechanism for doing that is also broadly the same mechanism in the short term. So that is all common. The element that I think you're identifying as a challenge is the process by which, or the capacity that you have for external contract management. That's essentially what you're saying.
Yeah, I just want to pick up a few points on both the external and the internal, as well as Gareth mentioned there. So Jeremy Griffith, Director of Operations, NHS Wales. Significant amount of investment from Welsh Government in both the allocation you have at the beginning of the year, the transformation fund there, and then the additionality. From quarter 4 to quarter 1, the allocation provided to you was what you requested and the trajectory set. And we've seen that quarter and quarter 1 didn't deliver against what you set as a trajectory. Similar for quarter 2 then, and now we're into quarter 3. I'm guessing my question on that point is, what changes now for quarter 4? Given the there's 3 quarters there of delivering against your own plan and delivering against your own plan. And then the second part on the internal, picking up Gareth, the Vice Chair's point, is that you're treating turn rates, about treating people who are waiting, and they're waiting the longest in turn, is some of the worst in Wales, I guess, across most of the key specialties, high volume specialties. The rot rates, the removal of patients you've alluded to, I think you thought you had a grip on, and you've evaluated yourself quite well on the enabling actions, but that probably needs to be reassessed now given the data issue. So there's what are you doing differently on the external, and then what are you doing actually on treating patients in the turn they enter the list, as well as those removals coming off.
And to begin responding to that, Carol, please.
Yes, thanks very much. If I crystallise the problems that we've had, two big problems. Mobilising the contracts, really significant number of contracts, complexity of contracts, and the administrative stretch. We have recruited significant numbers of additional administrative staff to support not just the 1-4s, but the 2,500 patients every weekend to come and have an appointment. That's quite a lot of administrative work. Outpatients, yes, outpatients. And across a number of programs, there's been a significant stretch. So those two things have been our Achilles heel here. So what's going to be different on quarter 3, quarter 4? We have now mobilised a stronger, I think, contractual approach to managing our contracts. And again, a colleague has joined us from the organisation to support that, and will be shoring that capacity up even more. We are filtering our patients more effectively so that we screen them before they go, rather than sending lists of patients who then get passed back to us. That does take administration, but we're putting that in so that it's quicker and more effective, so that the providers don't have to sit through that and then tell us that this patient is not acceptable. So there's a lot of work that we are doing differently, very much tracking and provider managing. On treat in turn, this is a particular challenge for us, because when I had a look at how many patients are being treated within what was the standard in Wales of 26 weeks and then 36 weeks, it feels like a very long time ago since we were dealing with that. We are seeing pockets where that is at 53%, 60%. I'm needing to understand whether that's about urgency all of the time, or whether that's a treat in turn issue. I mentioned that we are not a single health board, that we have 3 patient treatment lists, and we have to have a bureaucratic process of transfers of care. We are starting to move towards more single PTL. We need to have the data infrastructure to support that. And with that issue earlier on, that was that is a lot of work for us to do. And then on removals, Clara may wish to comment on this in terms of clinical validation of lists to ensure that the patients on the list really do need the procedures. So we will be implementing a programme of clinical validation to build on our clerical validation.
Now, just before anyone else comes in, I just want to get to Jeremy's point about Q4 is weeks away. It's 3 or 4 weeks away, and we're effectively at the end of this quarter, month away. So you're describing quite a wide range of interventions. How realistic is it that those will be able to be deployed at the scale that you feel is necessary in order to make the change that we know is necessary within that time frame? What's your assessment of that?
So where we have contracts already in place, and when we've done the assessment with the providers, we are confident about certain specialties being able to be supported. There remain gaps. So I would love to be sitting here saying there will be no patients waiting at the end of March. That is what we all want. But the reality of it is that we are still likely to have some specialties, particularly because of subspecialisation, where we can't get a certain specialty in a certain contract that are outside of that time frame. So the confidence, and we've had a bit of a reflection within the health board, because we've always wanted to set very challenging, ambitious deliverables, and Jeremy is completely right in that we have failed consistently to meet those for the reasons we've set out. So we are being a little more cautious and realistic about what we can do as we try to build this capability and the capacity. We will be meeting with officials over the next week or so to be starting to nail down where we think what to fall in.
Okay. There's more to talk about implant care, but I want to provide some time to talk about urgent and emergency care, where there are a number of things that we need to discuss. So, Jacqueline.
Thank you very much, Cabinet Secretary and Dave. It's very nice to see you here, and it's nice to see you more friends. So, thank you very much, Carol, for facilitating my visit a few weeks ago. You were very open and very warm in your welcome for me. And thank you for allowing me to wander around with your new medical director, with Dr. Day, to talk to staff and see actually how Wrexham Mailer was actually working. As you know, I talked to you afterwards about the concerns I have about patient safety, particularly in the emergency flow in the emergency department, and the moral injury that staff are feeling when they talk to us about that. And I'm really wondering since then, and we talked about some of the things that actually could be done at some speed to try and release your STEC and your acute medical unit to actually begin functioning as it should. 7-day discharges, because at the weekend, as you know better than I, you go from 40 a day to 3 at the weekend, and then that all stacks up for Monday, and then we go through the whole roundabout again. But I suppose that just the degree of urgency in the programme to put in place to actually see flow improve and therefore improve the safety for patients and actually for staff. So I just would like to understand from after we talked about that, where you are in beginning to actually implement some changes to benefit patients.
Thank you for that. I'll bring colleagues just to emphasise as well your visit and the insight you got there. We also highlighted this in our September board.
We did.
And that has given the organisation a bit of impetus, I think, and connection with staff actually because of that, which I think is very welcome. I'll bring Claire in to begin with, maybe, Claire, if that's okay, and then the colleagues may wish to contribute because I know of the work that is happening in this area in response to that.
Cyfrifol Gweithredol Meddygol, I'm the Executive Administrator there. So,
I'm fairly new with
Yes.
and she's doing really good with it.
So obviously, as medical director, I always want patients to have timely access to care, be that 104-week wait or, as we're talking about here, emergency care or anything in between. And have concerns with the clinical executive associated with emergency pathways. As you said, I was able to get around all of them within my first 2.5 weeks, which again, really helpful. And working hand in hand with operational and other clinical executive colleagues across to be able to do this. And there is always a link, obviously, between performance metrics and how we measure performance and quality itself, but there are other things associated with quality that we wanted to unpick a little bit further. So, I'm sure that Tamina will talk about the performance aspects, but we've also held a quality summit associated with emergency care last week on the back of all the performance elements, which we feel complements it. So as well as us thinking about 45-minute waits and 12 hours in the department, we're thinking about our time critical pathways as well. And it's very important for me that patients are able to access their care and staff are able to provide the care that they need to be able to do. So during that, we talked specifically about how we measure quality of care, not just performance targets, and how we change daily operational processes associated with that. So as clinical execs, we are about to issue a set of updated quality standards for emergency care early next week, which will include a reminder associated with professional standards and a reminder that the care of those patients in ED and emergency pathways, and indeed those pre-ED, is the responsibility of everybody on the site. And so although we see the bottleneck within ED, of course, it is the flow throughout the hospital that's important. And within that, we, as well as looking at normal incident reporting, we will set aside some certain must-report events associated with quality of care, as well as looking at time-sensitive pathways such as treatment of myocardial infarction, stroke, and fractional conclusion. But I see this as very much linking into the performance mechanisms. I'm happy to talk further about how we're trying to prevent harm, but I don't know if you want me to do that now or to hand over to performance in the first instance.
Yeah, so should we hear from you, Tahima? That would really help. And also the things about when flow isn't working in the hospital, the risk ends up in the emergency care department. So the bit for me is where you're starting at the back end with some of that in terms of the discharge end.
Yeah, absolutely.
Diolch yn fawr. Tamina Ranchmal, dwi'n Prif Swyddog Gweithred.
So I'm the Chief Executive Officer
At Betsi Cadwaladr. I started in April. It was really lovely to have you visit, although I recognise there was some real challenges around the visit and what we were sharing with you. And I did want to just re-emphasise, we've said it a couple of times, the challenges are experienced most significantly in the department by patients and our staff, but the problem doesn't sit with the emergency department. It sits in terms of what happens before in the community, how we manage people right at the front door, but really particularly the back part of the hospital. And the fact that at the moment what we're not seeing is the equalisation of that risk. So the risk also sits within the department rather than being shared equally across the whole of the site, but also in our community services as well. So in fact, one of the areas we have particularly started focusing on is around the back door and the discharge in two particular elements. But I'm just going to take a little step back. I did want to say we have some phenomenal staff working in some extremely challenging circumstances. We have patients who reflect on their really positive and effective care and treatment when they're able to get in front of our clinicians, and the issue is the time it takes for that to happen. And we do understand there's some physical and moral harm associated with that with all of our patients. It was escalated as basically our main priority in the September board, which I think is really important for us to be sharing externally as well as internally. And for our staff within the emergency department, I think there was something about the recognition of that they found extremely helpful and empowering to some extent. We have been working on the 6 goals around how we improve urgent and emergency care. But what we've now done is focused on each of the particular elements, taking 1 or 2 really key priorities that we think will have the biggest and also the fastest impact to try and sort of change what's happening in our EDs at the moment, particularly to get on the front foot before we get into winter with the main demand.
I was asking, so
yes.
What would you say is what are the top 2 or 3 things that you think are going to have the biggest impact?
So
and if I'm a patient in Wrexham or in Llanglwyd or in Spentigwedd, how quickly will I start to feel the benefit of those changes?
So we see around 100, say in Wrexham, we see around 170 attendances in the department. It was billed for around 70, so it feels quite crowded in there. So one of the first things we're doing is making sure we're utilising all of the other opportunities within the site immediately so that people are streamed as soon as possible to the right place. So we have an urgent treatment centre. We want to make sure it's used really consistently. So what we've agreed is to enable patients to be moved around there, so there's a bit more space in both of those areas that we will put a nurse into manage that department. I think, Jacqueline, you saw that we have a triage room that our acute consultants use to do assessments. When we're really busy, as part of our escalation, we've had a sort of custom practice that we then bed people in there because it's a side room and sometimes it's safer. So we've just removed that as an opportunity so that that can continue to be used as a triage area, which enables us to get the flow out of the department into that area so our acute consultants can see what they're doing.
That's a red line, effectively.
So that's an absolute red line for us. And in a couple of our other departments, we're doing something, our same-day emergency care, when it's really busy, particularly the weekend, we bed patients there. So we're saying actually, incrementally we reduce the number of beds we're allowing there, so we get to the point where there are no beds allowed there at all, and that's really important for us. And that's something about how we manage the risk with our colleagues from the ambulance service. And I should say I meet with them every week now to look at our improvement actions from the previous week and the coming week, so we really feel we're working better in partnership around that. But I think the point you were making was around discharge and flow. We've done something we started this week, so to increase the number of discharges we can make into care in residential homes, we're now phoning those care homes to follow up on those patients. It's a 5-minute telephone call. It's really well received. It's increasing the confidence of those care and residential homes to take people, particularly at the weekend. And at the moment, we've been in for 3 days. That's been 17 patients. We've had no failed discharges, which from my perspective is really important. We've tried that just in a couple of the areas in this morning in Gwynedd, and we'll be rolling that out to the other local authority areas. And then the other thing I'm looking at particularly is package of care delays. So at the moment, I think at the current, we've got around 13,500 bed days delayed, and of those, just over 8,000 are related to package of care delays. So we've just launched within Stream, which is a data analysis and recording system, if you like, we can now show live data on the patients who are delayed waiting for support in our hospitals rather than using just the point in the middle of the month. And we've been doing some work with each of our 6 local authorities. So by the 8th of December, we're hoping to see something like a 5% reduction in package of care delay days. And by the 22nd, as we begin to segue into that 2-week of reset, that we can then actually reduce that by 10 to 15.
So if I went back round the ED in Mailer and the AMU, what would they be telling me now?
I think they would be telling you that, I think they'd be telling you two things. One is there's much more visibility now, but I think it's probably worth saying visibility is sitting with the executive team. I think they'll see that that from a clinical executive and operational executive, we're working much more closely together, and that's enabling them to challenge, I think, some of the practices that they've had, but particularly patients who are waiting in ED, waiting for a bed that might be there for 2 or 3 days. As we increase those discharges, they'll be able to be moved to the wards much more quickly. And I think that will both reduce congestion in the ward, and it will also take some of the pressure in terms of them effectively managing an acute medicine ward rather than an ED, so that we have our clinicians able to do the job that they want to do rather than the job they're having to do.
Thank you very much. We're going to need to move on to the next item, but I just want to ask, I still haven't got a clear sense in my mind when the board feels that a patient turning up to one of the EDs will have a markedly different experience. I know these are the elements which are obvious, which aren't entirely within your control, but what is the board's level of ambition in terms of timescale?
Yeah, I think from what we've done over recent weeks, we have far more confidence now than we did. And I think we're hoping to arrive in a much better place December. And Carol, you want to give some detail around that, maybe?
Say that we've got about 40 days until Christmas, I believe. Not long, honestly. And there are some very clear things that we need to do for Christmas. We need to discharge as many patients as is appropriate to do so before Christmas. We need to have confidence that we can protect SDEC, same day emergency care, and AMU. I was in Wrexham Isle last Friday afternoon, evening, in Betsi Cadwaladr Monday morning, to have a look at those. They help the clinicians to keep the flow moving through the system, and we need to have implemented a forward patient flow. There's a certain phrase around that, but that's what I think people understand it to be. So those three things will make a difference by Christmas.
Okay, thank you.
I just wanted to make one general point, which we may pick up in the discussions we have, and that's what I refer to: local leadership and accountability. I think that's what we're hearing we need to build. I think we've got that from a corporate level.
So you're saying hospital level?
Absolutely, okay. Absolutely. And I think that's what we've learned from some of the work in recent weeks, and that's where the potential is actually, but we need to drive it. And to me, you picked up that.
We're going to. Absolutely. I don't think we've got much change at one point he wants to make, but I'm just conscious of the volume of discussion that we need to have.
So speaking as a clinician and being aware that this is a public meeting and that members of the public in North Wales would be listening, I thought it was probably fair to say, given all the things we've been discussing now, that the nationally reported data that looks at the outcomes for patients as seen by your clinicians actually place you overall as the health board in Wales with the best outcomes. So once someone gets in front of your clinicians, they get fantastic care. And I think it's really important for people to hear that. And hopefully if we've got a bit more time later, it'll be nice to cycle back to understand how we're making sure that people on the waiting lists are safe as well. But I thought it was important as a doctor just to say that.
Thank you. Appreciate it.
Thank you. Diolch. We're going to move on to the second of the areas that we're looking at today, which is how the health board is adapting services for the future. So I'm conscious you spent quite a large amount of the meeting on the first area, which is right, because it's a critical area. But I would just ask everyone to bear in mind in the length of their responsibilities that we have quite a lot of discussion yet to have. So who's going to help us with that?
I think it's Clara to begin with on this item. Thank you.
It is. So I'll give you a brief overview of some of the services. So we're very clear that it's important for us to build services that are sustainable and patient-centred and fit for the future, as well as dealing with the here and now. So from a women's health hub point of view, we've got a Pathfinder project going that will open in March 2026, which is working between primary and secondary care to provide care close to home for those patients. Maternity services, we're obviously participating in the current review, and as we've discussed, we've got Badgernet, a digital system, to be implemented next year. Mental health services, we've had a lot of focus on over the last few years, and following the Royal College of Psychiatrists review of reviews, there's been a lot of work associated with that, with 56 of the 80 improvement actions now complete, with clear and others with clear plans in place, and we're due, as we've discussed, to put a mental health electronic health record in next year as well, which was the subject of many of the previous Prevention of Future Days. Council performance has also improved and is meeting assessment standards and reducing waiting times. And we are constantly thinking about community by design, and we're thinking about our community models to redesign, to reduce out of area placements particularly, and to strengthen crisis care. Prevention is, of course, central to our strategy and is vital within our development. We've got a prevention and anchor framework with partners, which is to tackle wider determinants of health as well as healthcare itself. Vaccination programmes have had a real note towards health inequalities, but have got good performance about COVID and flu for this winter. And our childhood programmes have also got good take-up. Smoking cessation programmes have supported nearly 2,000 adults this year also. And we're redesigning diabetes pathways and promoting physical activity through, again, multi-stakeholder engagement. Community-based care is, again, a real focus, and we're embracing community by design. We had the Chief Medical Officer up just recently looking at some of this. We've now got audiology out and integrated into primary care, which has been very helpful. We've got local models such as the community assessment days, which the AHPs have been running, which brings many people together and helps kind of earlier care and reducing waiting lists, and integrated care models in one of our clusters like South Denbighshire, where they really embrace the kind of co-location of all the professionals and working together to prevent deterioration and admission. And again, it's building on those that's really helpful. We've got health and wellbeing hubs, either in process already operating, and we'll have several of those in next year as well. Digital obviously transforms all of this. We've mentioned several of those already along the way. We've also just implemented the risk for the radiology information system, and we've got electronic prescribing coming before the end of the financial year. And of course, we are excited about moving to a full electronic health record in June time. So that's just a brief summary, but obviously it happens.
Thank you very much for that. It's helpful to get a sense of what's underway. And I saw the vaccination figures, which are really very positive on this. That's good news. So I wanted to talk about the clinical plan. And it's been some years since the board had this group plan. You need to develop a strategy, a clinical strategy before that can happen. So I would like to understand what the timeline is and what the approach to governance is for delivering a clinically led plan, and what you expect to do by way of engaging clinicians and the public in how you develop that. Mindful that a number of the challenges that we've been talking about depend on that in order to achieve a long-term solution. So obviously not having that in place will be hampering your progress. So.
Right, well, I'll talk about the process and timetable. So I'm the temporary acting chief executive.
Transformation and strategic planning. So we've embarked on quite a space in relation to our strategy development. We see it as absolutely vital, hand in glove with our operating model, helping us to work regionally across to solve a lot of the challenges that have come up, have been mentioned already. We're configuring the work in three strategic products. So we've got our strategic intent, which we're co-creating with partners across North Wales. So that's for the population as a whole, not just focus on health. And that is with the board for sign-off in January. And we're in parallel with that, we're also working on the 10-year strategy, which will be the overarching framework for where we intend to be over the next 10 years. We'll be completing the discovery for that at the end of Q1, and we're seeking to design and publish that in Q3 next year. And our clinical services plan, we've split into two phases. So the challenge services that you'll recognise under the special measures framework, we've been treating that as our phase one, if you like, of clinical services plan. So those things are a bit too urgent to wait for a broader view of how we're going to configure services across North Wales. And I'm sure we'll touch on those as we get to the relevant section, but there are eight services within that, 2 of which are currently being considered for de-escalation. So there's been some good progress in that space.
So can I pause you there? Does that allow you to operationalise some of that in advance of having the full planning?
Absolutely, yeah. So a number of our specialties, so urology, for example, are having workshops and have had workshops over the summer around the configuration of their services and the emergency on-call rotas that's unsustainable. And we're working with them on addressing that. And that is in advance of a bigger clinical services plan. So there are a number of examples of those as we go. And then the bigger phase 2 clinical service plan is where we want to look at the full picture for North Wales, thinking about what do we need to do closer to home in communities, what do we need to do on 3 sites, on 2 sites, on 1 site, and what do we have to form strategic partnerships with providers outside of our boundaries. And we're expecting to complete the discovery phase in Q2 for that, and then we'll take a tranche approach, because clearly if we get the full picture of it, so there's a lot to get through. The first tranche of that coming through design in Q3 next year.
Okay, thank you.
Thank you very much. So you've actually got quite a lot of service change happening quite soon as well. So you've got the orthopaedic hub at Llandudno. I think that's nearly close to completion, is that right?
Yeah.
And developments in the Royal Alexandra Hospital, Gablet unit, service changes at Tywyn and Penley, community hospitals. So quite a lot going on. But these changes need to be actually made in a way that actually makes a huge difference to the local communities. And I'm just wondering what oversight that the board has in regards to not only completing whatever works need doing, but actually getting the model, the engagement, so that when these changes are made, actually you can really work at some speed to make some difference.
And that's why, for example, with Llandudno, where it's been quite a considerable capital project, we've also put in place work with clinicians to ensure then that clinicians can share that ambition and be in a good place to deliver more productivity in that location. So we are trying to do both things at once. But maybe, Claire, do you want to talk as chair of a very long name, which people, population, health, but yes. I don't know if you want to talk a little bit about that.
Grandad Powell, Claire Dwi, Aelod Annie Bernard.
So I'm independent member.
I think I've prior to working for health, I've been on the health board. I've worked with Flintshire Council, and I guess that's a relevant point here, because I think in terms of what's different, what's happening in terms of a change perspective, what I can see within Betsi over the last 18 months or so now is our work around engaging people around service change and understanding local needs is in a significantly different place than it was previously. So if we talk about Penley or we talk about Tywyn, the work that we've been doing with those local communities and stakeholders and our staff in those settings around what future models of care, what future service delivery might look like, is very different than it used to be. I think Betsi used to be known in the past for kind of almost having a plan and just checking if people were okay with it, rather than working collaboratively and cooperatively to build things up in terms of what matters to people in our local community. So through our committee, we have regular reports on all of the change programmes. We've had great feedback this year around our winter plan from local government, who've said it's really felt like it's been a collaborative approach this year, and that hasn't felt the same in previous years. So I think in terms of how do we co-design, how do we design things that are going to meet future needs, I think we're in a very different place than we were previously. We still have a lot more to do. I think we want more work to do to build the trust and confidence of partners and people that when we engage, we work together on things. So the work on the 10-year strategy, we had a really great workshop facilitated by Bevan a few weeks ago, where we had a whole host of partners and clinicians and staff there, all in the room together, starting to develop and shape what our 10-year plan is going to look like. So it's
you go first, I go next.
So I was trying to get to the question asked about, you've got some things coming on board now.
Yes.
Yeah.
And if we just take the Llandudno orthopaedic hub,
Yes.
I suppose if I went and talked to your, maybe ask Clara this question,
Yeah.
your orthopaedic consultants, would they say, right, what we know we're going to do is we're going to do 4 hips a morning, so we're going to do one a day, we're going to do, you know, no overnight stays unless, or etc. etc.
Yeah.
Would they be absolutely there with the model and absolutely know what they're going to do and they're ready and they want to go? That's what I'm trying to
I hope so, but I think that's either Clara or to me to answer that more specifically.
Yeah.
Do you mind if I add to that question?
Yes, please.
So,
James,
so
you
the
can pick
answer
that up in
once.
yeah.
So the point Jackie makes is very good about, you know, how the surgeons are going to ensure that they're productive within the new facility.
Yeah.
Because, you know, the new facility is just a nice building unless everybody's on board with making it really sing the population of South Wales. So Carol alluded to a problem at the beginning that at the moment, you work as, some of the groups of clinicians work as 3 separate groups of clinicians. So I think the hub will only be safe and cost effective if the orthopaedic surgeons, and I would hope that they lead it, agree to use the minimum number of prostheses possible to meet the needs of the population. And that should be clinically led and management enabled. So can you assure me that that's the journey that you're on?
Do you want to, or Carol, do you want to give some insight of both?
No,
Okay.
Yeah.
Okay.
It's not long now until Llandudno is finished and goes live. So you won't be surprised that we're meeting every week to discuss, okay, where's the capital at? Have we got the electricity switched on? Have we got the testing? And how are the clinicians feeling? And what's the take-off of clinical care? Because we're very clear that business cases for arthroplasties, for joint replacements, and that is the standard. What is the plan, guys, to get us to that point? They have a clear plan. There is something, and James, you'll appreciate this, about the types of patients that come to that unit, and that's going to be new for us. And I think that will be something for the clinicians to sort of settle into. But they are committed to look after ASA 3 patients there. They've been to other centres in England where that is happening, and the level of ambition is high. What I can say is that our orthopaedic service across North Wales is very innovative. You will see that they have won awards for carpal tunnel, for all sorts of green hand surgery, so they are up there. This will challenge us, however, on moving from that 3 model to one single model.
Yeah.
And we expect to still have to operate that change process, the hearts and minds, as well as the, you know, have we got the right list and is it all, you know, managing, etc. And are people from Wrexham coming to Llandudno and are people from Aberdaron coming to Llandudno? So we know it will take a bit of bedding in. That is why we're having these weekly drum beats now in readiness for our first patient, which we anticipate will be in February.
There has to be a commitment to that change, because if you can't standardise practice around a fantastic new building, what will they coalesce around?
Yeah. Can I want to get a sense of I think I hear what you're saying. It's great that you up the innovation in orthopedics, which is fantastic. But are you saying, what's your confidence level that you will have that aligned practice and that they will be? I'm not particularly choosing that service, by the way, but it's what we happen to be talking about. So what's your confidence level that you will have that aligned clinical practice that gets you into that joined up model? And how do you then plan to use that in other clinical specialties where presumably you want to do the same thing? What's the board's view of that?
Clara may have a view, but
sure,
recognising you're only a few weeks in, so I have a bit of time advantage here. There's a real sense amongst a core cohort of orthopaedic surgeons who want to do high volume operating. There will be some people who want to operate on more complexity or revisions, and they will happen in their DGHs. There's been a growing sense of working across the region, not just in orthopaedics, but I've been to dermatology events, gastroenterology events, maxillofacial and ENT events, and you just saying, Paolo, in terms of urology. There is a growing recognition that the only way to have sustainable services in North Wales is to work as regions. Now, that is quite a challenge as well in terms of the level of service change, and Jacqueline's absolutely right. There's a lot of service change to come. This is something that we need to be much more capable of as an organisation, and that is part of the organisational development. But we're really clear that services can't stay as they are because they aren't sustainable. Gert has told us, for example, you're trying to run 3 acute rotas, I won't say which specialty, because there's a couple of them, over three sites. That isn't effective, that isn't modern, and people don't want to work in that way. This is one of our biggest challenges now, is to change the shape of services and work much more as a region. And Llandudno is a bit of a test for us, to be quite frank.
But it's also a good example where we should be playing to the strengths of having quite a large health board and having that capacity across the region, rather than we find ourselves having to work with the disadvantage of it. So Llandudno, we see as the potential to be a centre of excellence. That's what it should be. And I think the clinicians share that ambition. So that's why we're hoping to work on that. But it's playing to the strengths then of health, but drawing on the clinical expertise across the region rather than having it dispersed.
Can I just ask you a further question before we move on to the point that Claire, you were making about public's understanding, the engagement with the public, and you're saying that is that's moved on considerably and so on. David, what's your sense of the public's understanding of what you're trying to do here? Because, travelling from different parts of North Wales to Llandudno is a really practical challenge. People will be up for it. So I get that. I don't really mean at that level, but you mentioned the fact that you're moving from a model which is very distinctively 3 geographies into something which is organised differently. So that will be quite a complex thing for the public to have a clear understanding of, unless the board is clear about what it's trying to do there. So where are you with that?
I think there is something in terms of that discourse and the conversation with the public where we need to explain that we are trying to develop the best possible service for our population, and in this specialty it's going to be placed here. I think the population of North Wales are quite used to travelling to access health services. Actually, I can go back quite a few years where my brother was in Gaboin, for example, to have a knee operation. Going back all those years, historically, we've gone to Liverpool, we've gone to Manchester. So travelling a distance, what people tell me, I don't mind travelling if you tell me it's the best I can get. So there's something about that, I think, in terms of explaining what we are building and what we're trying to do to ensure that people can have services here in North Wales that will provide the best possible service for them and their families. And I think people are ready to respond to that.
So Llandudno matters a lot in that context, isn't it? That you could demonstrate to people,
absolutely,
here is a service that's delivering efficiently the best possible levels of care. This is what we have in mind for other things. So that's essentially the message.
Absolutely, and historically, we can turn around where people have had to go outside of the region to Gaboin, as I was referencing. It can be Llandudno now, which is much better, and will help build up the service. It's not just a message for the population, but it's a message for our own staff too, I think, where we see, look, this is our ambition, to create the best, so that you as the clinicians will be able to operate the best. We will attract staff because we've got the best. I think that's really, really important for us as health.
Okay, thank you. We're going to move on to talk about finance now, which is the third area we're going to look at today. Finance and planning. So, which colleague is going to help us with that?
Okay, thank you very much. I'll turn to Russell as our Director of Finance to do the introduction, and then colleagues may wish to come in.
Yeah, so I'll give a brief introduction campaign and bring my colleagues in as well. We'll aim to stick within that. Really just to introduce the evidence back really and take you through the story quickly, if I may. So the Health Board has delivered some significant improvements, both in financial governance and performance, following exploration into special measures back in 2023. At that time, projecting circa £200 million worth of deficit, of course, annual accounts qualified in the 21-22 year, subsequently the 22-23 year. In response to that, though, we've implemented quite a comprehensive recovery programme over a number of years. There's been a focus on governance, transparency and financial discipline skills, reset components of the financial plan during the 23-24 year, and we've revised our scheme of delegation restoration and also standing orders, standing financial instructions, and clearly have a focus on procurement outcomes and contractual management within that model. We've developed some mapping tools, audit whales, full transparency, therefore all our transactions from accounts back to source ledgers. And we've done that to support that culture of openness moving into reporting on our financial position. But those measures that we delivered an unqualified audit opinion. We've had that now with audit whales giving us a clean bill of health for the 23-24 and the 24-25 financial year. And we've had no changes from draft submission of accounts outturn position to that of final published accounts. So really positive models. In 25-26, we set 23-24, sorry, our outturn was 24.6 million, and we improved on that to 7.6 million, and that was better than control targets, so a 7.6 million deficit in the 24-25 financial year. Moving into 25-26, we set a balanced plan and set a balanced plan through our entire integrated medium-term plan, of course. Only one or two health boards still forecasting break-even as we move forward, so it is a really challenging environment. And whilst our savings performance remains really strong and we've underwritten all of our savings for the current financial year, we have encountered some financial challenges. We are currently reporting circa 16.3 million as a deficit position, and there is risk to delivery of that position that will escalate up to £15 million at close of the year. And examples of those are the capacity pressures, and we've discussed that earlier, how these agendas merge really in that balanced position. But also there's been some national impacts in terms of cost profiles and costs that we've had to incur or providing for incurring that we weren't aware of setting of the financial plans as well. So some of those elements have come outside of the plan. We know that there are conditions associated with an £82 million allocation we have in our baseline position, and that clearly requires us to deliver and attain financial plan in the current year. And mindful of that, we have enacted a financial recovery plan. We have already embedded establishment controls process. We've got temporary workforce controls and oversight for escalation through Exec Director of Nursing, Exec Medical Director. And then we've got scrutiny of non-pay expenditure that is being overseen through my office, only for, of course, non-clinical.
So can I just ask you, did you say 16.3 for the figure you were drift by?
16.3 million, yeah.
Okay, so that's got worse since the evidence pack was submitted.
It has. So we've submitted the position for month 7, and the month 7 position is £16.3 million as a deficit. Yes.
So can you give me a sense of what actions? So you were just talking about some of the general approaches, but what, that's going to require you to make significant month-by-month savings between now and the end of the financial year to close that gap. What will that look like in practice?
So it's about how we've got all the mechanisms in place. It's about how tightly we've written those mechanisms. So we're working with our directors in areas. So we haven't just started doing this. We've had these conversations over the last 6 to 8 weeks. They've built the plans up in terms of the short-term actions that can be taken. We've endorsed those. There are medium-term action, but we are looking at impact assessments for each of those to make sure that we don't inadvertently cause disadvantage to other areas of the portfolio. And then we formed a financial oversight group through chair and the board to give oversight on delivery of those improvement mechanisms to control those costs.
But if those have been in place and there's been a worsening in the position between the last 2 months, what's your confidence level that won't get worse for the next month?
So it is a challenge for us moving forwards. It is a clear risk to us. We don't yet have the full plan underwritten. The 1.5% savings initiatives and the assessments that we need to undertake are still being actioned, and as a consequence of that, we haven't yet taken those actions and taken those costs out. So the magnitude of the savings we need to deliver between now and close of the financial year, with those additional pressures that we've experienced in year, are substantial for us to deliver between now and close of the financial year.
You're still projecting, as you said, a balanced position.
Yeah.
We are still projecting that balanced position, yes, with that risk evidence that we need to mitigate.
Yeah. So it's probably worth noting, as a percentage of our overall budget, it's a small percentage, but it's also worth noting it gets more difficult the sort of smaller it gets, if you like, because we've done
closer to the end of the financial year.
absolutely.
Yeah.
So that's where the challenge. We're also facing with some pressures, with potential extra costs and so on. So we've got a lot to do in the next few months, I think.
But it is worth saying as well, and this is not it's not saying that there's any inevitability about it, because there's quite a lot of blood, sweat and tears goes into it. But
Yeah.
in the last couple of years, we've been in a similar position where in the first 6 months, we were significantly out of profile and we were able to bring it back. As I said, that's not to say we're absolutely certain we can do it, but we have got the track record of doing it. So
Gives you some assurance.
1.5%, I think, of our overall budget.
So, Grant, Jules Goodwin, Credit Director of Finance. So yeah, the key question for you is, I think there's a consistency to our interaction all year that I think we have to recognise around risk to delivery, but increasing confidence that you will. We've planned on the basis all year you would deliver your plan. I think at the Cabinet Secretary's question, we're now at the end of November. So what immediate short-term processes have you got in place to give you that confidence, and when will we have it? Because we need certainty at this point, and we don't yet have it. So when is the question, I think.
And then we'll bring Carol in, maybe.
Yeah, so we are working on all those mitigation actions, absolutely. So we've got line of sight. We need that for the health board, and through our interactions, we've had those conversations about we need that immediacy, really. We are 2.51 billion, so we spend over 200 million pounds a month. So a 16 million recovery position is within our grasp to do so, of course. And that's the conversations we're having at 1.5%. Between now and close of the year, those mitigating actions can bite, and we can deliver those. It's making sure that the consequences of doing those we're all comfortable with as a board, and absolutely understanding what impact that will have in the other areas of the organisation. So there are decisions to be taken, clearly, and we will get to conclusion of those within the next matter of weeks.
So the when question is answered by a matter of weeks, right?
But also having to control the risk that's been highlighted as well. So not just delivering on what we've said and the current overspend, but actually we can see the risk as well. We've got to tackle at the same time.
Yes. Check it.
So you said something really interesting, which was, so it's happened quite a few times where at the beginning of the year, we sort of get into deficit and we sort of sort it out in the last bit of the year. So I suppose my challenge to you is for next year.
Who's can we do it better?
You don't do what you keep doing, which is doing that, and actually start now planning next year so that you don't get into the problems you've got. That doesn't give myself and Howell, and I'm sure the Cabinet Secretary, saying, well, we usually do it, great confidence, because what if you don't? I'd much rather you sort this out at the beginning. So that's fine.
Do you want to respond then?
Request.
Maybe.
Actually, to all those points, if I may. When we came into the health board, this is not a health board that has had a great financial track record. So as a board, we are committed to meeting our statutory duties. We know there is some distance to travel to the end. We will be able to see, the public will be able to see, and our staff will be able to see that we have grabbed hold of this agenda and we have made that progress. We also know that we've got a lot of money, £2.5 billion of public money, and how we spend that, how we deploy that is very important. So our work to build a sustainable financial plan that delivers better services is the aim here. We have had to hold this organisation quite tight on the finances, and that is a really tricky balance for us as a board in order to, deliver the ambition that we want and that consistent improvement, but also give autonomy and support and accountability in the right places. So we're making that journey. So that mid-year grip is us gripping harder when we feel we're not quite a mature enough organisation yet to really feel that we can deploy that financial discipline confidently through the organisation. It is coming. But we do, staff will be listening to this. We do at times have to grip the organisation a little harder than is being used to. By the end of this current financial month, so end of November and early December, we will have taken stock of where the 1.5% additionality, where our holding of certain roles. We've got a big structural change coming. We've been holding those roles. where that gets us in order to better inform for yourselves in terms of obviously what the likelihood of landing at our break-even position is. But we are working very hard on this.
Oh, so on the when, we've heard next few weeks, I think your mid fate position is going to be pretty critical, and that's sufficient government, so we need to follow up on that. I can extend Jacqueline's question into a sort of different one, because I think it builds on that point, because some of this is about kind of repeat patterns of what we see with the organisation. So the cumulative savings delivery in year is one. I think there's a second one, which is, and I'm struck by the comment Gareth made up front around this isn't a challenge of more resource, because obviously we share that view. And I think comments
revenue capital is different.
Comments in the meeting are kind of validated that.
Yeah.
So another observation I make is, despite all of the variation we've described in this meeting, it's a remarkably small percentage of your savings delivery plan currently. And a number of the in-year pressures described, flow in particular, translates to the financial pressures you're trying to address in year. So again, going into next year and building on the improvement 3, I'm interested in, what do you consider to be your biggest areas of financial improvement opportunity, and how would you grip them now in the context of the improvement work, and how does that build into what you're going to do differently next year?
I'll bring Gareth in a minute. I want to underline the point. The board has a particular appetite to have an absolute clear view of what we're getting for our investment. I don't think that has been the case in the past. So we are really keen to ensure that we're aligning what we're investing with outcomes for the population, for patients, performance in general. But Gareth, do you want to?
Yeah, I'm going to leave Russ to talk about the value and sustainability, because as the chair of the feeder committee, I'm sort of seized on what we're doing. I also know there's a lot more potential there, and actually it's not entirely clear, but most of the 40 million service savings that we've realised in line with our target comes from value and sustainability work streams, rather than sort of just grabbing little bits of money here and there. But the other point I do want to make, and it's probably more to do with Jacqueline's question, is that and sorry if this sounds like a confessional, but it is true that the budget structure we have is not very transparent, because it comes back to the operational model, that the vast chunks of the budget go into the 3 IHCs. So if you ask me how much do we spend on renal care, it's really difficult for me to tell you. So we are going to have to Russ is working on restructuring the budget so it is much more transparent, and it's linked to that one health board agenda rather than having these silos. So I think then it will be much more possible, because I feel passionately, I mean, there's no disagreement here. I think the central grip has been necessary to get us back into some sort of decent level of financial control. But what we absolutely have to do is build a culture of managers taking budgetary responsibility, which I don't think has been there in the last few years. So it's a bit like the plan here. There's the immediate, what can we do to cope with the immediate problems through crisis? And then there's the longer term transformational change, which will get us out of the hole of just doing the same thing. Yeah.
So given that, how do you, as you approach the need to make choices over the coming weeks to get back into balance? And you've talked absolutely correctly, obviously, about understanding the risks of making some of those choices. If the budget structure is the way that you described it, how can you make sensible risk choices about where you make savings if that isn't apparent at a service level? How does that play out in a board discussion?
Can you want comments to begin with?
Yeah, thank you. And this plays to the point about how much do we grip and direct, and how much do we say to budget holders?
Yeah,
you need to reduce expenditure by 1.5%. Over to you how you wish to do it, or do we say these are the areas we're expecting, and so therefore we are holding vacancies or whatever? And the health boards are using a variety and therein lies our maturity, because at this stage we've taken a reasonably directive centralist approach. We do take obviously quality impact assessment, risk assessment around these things. But when we're looking at the shape of our budget, it's mostly workforce. We have some non-pay controls already in place. And these start to talk to our more difficult areas, because the last thing we would want to do is start restricting workforce in the areas of greatest pressure and then add that. So this is the sort of the dilemmas that we have been having the discussion in the financial oversight group that we have established. The quickest and easiest way is a very clear directive grip on the organisation's finances, but it's not a sustainable way.
No.
Okay, just one final item on this before we move on to the last agenda item.
Yeah, I think for me, it's joining some of this together and being clear on the how, because we are going to embark on the planning process for next year. And I think there's a maturity reflection in your organisation describing of short-term, it's grip and transactional savings.
Yeah.
Longer term, it is about addressing variation, effectiveness and allocative value for a £2.3 billion organisation for the whole of North Wales.
Yeah.
We absolutely agree with that and happy to support that. How are you going to do that in your planning process? Because we've had a parallel conversation about improvement, service plan for the longer term. This needs to be ingrained as part of a single approach.
Yeah, just give a very brief answer on that, and the rest may wish to come in as parallel. So we are shifting the organisation, as Gareth said, from buckets of money to specialty service areas. We know, for example, that we have increased the amount of money put into urgent and emergency care over the last 5 years by about 67%. That is really significant investment. How do we reutilise that money in the best way to support better care and outcomes? So service by service, a realignment of those budgets in those specialty groups and a redesign of the services we talked about, haven't we, in terms of the plans moving forward. So it's part of the transition. I don't think we'll get there in one fell swoop, in terms of this year, but that is the direction of travel.
Right. Okay. Diolch. We're going to move on to the last of the four elements that we are looking at today, which is how we strengthening how we run the NHS and what that means in the context of the board in particular. So just a very brief position for the board before we ask some questions on the approach which you're taking, David.
I'll ask Pam to give a general overview and maybe that's the full want to say something and then short panels.
I ask you to be very brief.
Yes.
That because I do want to hold that to 4 minutes between you and make this a little discussion.
I will be very recent. How come I literally with all shower drinking? So I will be director of corporate governance, been with the health board for approximately 15 months. So just really in context, we've heard Cabinet Secretary through today around the work that the board's been doing in terms of strengthening the organisation, its governance and accountability, and also in terms of the way in which the board operates, in terms of openness and transparency. And that's a clear stance that was taken by David and Carol back in 2020. Just important to note, whilst the new board was appointed in 2023, there's been quite a lot of in and out, if you like, with interim appointments. So I think just wanting into some of that. And then I think without going into too much detail, because to allow for times for questions, the progress I think is well documented. One from Audit Wales, Health Inspector of Wales, Welsh Government in terms of our governance, our leadership, quality improvements. But I just important to say we see this as a board operating with the highest standards of corporate governance, being open and accountability as public servants to the people we serve. I'll stop there because
that's very
helpful.
Secretary, we have met before in a role of I just wanted to give a play to committee work, which is what Pam was talking about. And, you know, that is where public accountability is being demonstrated, because there is strong discussion. You know, there is some scrutiny, some challenge, some question and answer. And from what I've seen in the audit committee and in the quality, safety and experience committee, I see one group. I see a really strong relationship. I see executive directors and others coming to present information, for example, when we do deep dives, and welcoming questions, happy to explain. But I also see a lot of enthusiasm, a lot of commitment, and I see a real strength in the way that information is brought to us in a live way rather than reading a document. So both Carol and Tamina come to the committees and they talk about the discussions they've had with clinicians on the ground and how excited they are and how the engagement is progressing. And I think for us moving forward, a lot of my belief that we will do it is seeing the strength in the committees we've got, but also hearing about how that strength is being reflected down through the organisation. So I just wanted to give you a flavour of, what it's actually looking like in those committees now, in terms of, having an overview and having a belief that we are moving. The chair of the QSC, the last report from board that she prepared, she commented that she's got much more assurance now on the challenge services, because there are clear patterns coming through that things are improving. And we know too are de-escalating. We're focusing a lot on regional provision and also engaging with clinicians. So, there are real positive growths coming through there.
I want to go on to that, actually. That's a very one of the issues I wanted to discuss with you, David, is, there have been a number of external reviews in different areas that have touched on some quite common themes, really, around clinical voice, clinical culture not being historically where it is needed to be. And you just touched on that in your remarks there. So I'm keen to understand from the board, from the point of view of changing that culture into one where we want it to be, what are the specific actions which you are taking, and what else have you got coming up? What else are you planning to do to improve that culture?
So I think there are informal and formal elements to that. In terms of the general culture of the organisation, we've got quite a big programme around culture, and we've got a cascade of individuals who are, I don't know the terms, culture champions, cultural change leaders, and so on. So we have attempted from the very start of our tenure to impact positively on the culture of their organisation, not only by being open and transparent, but meeting people where they are. There's one thing that has struck me about all this, though. We are not starting from a blank piece of paper. So we're starting from where there are different cultures in the organisation, depending where you are and depending on the people involved. So with our culture change programme, as well as driving that, which is really important, we've got to drive it locally as well. We've got to engage with people locally, and we've got to recognise that there's some culture that's not acceptable. And we've got to be firm enough to let people know when something isn't acceptable and what the consequences are, as well as being positive, open and transparent. Those two have to go hand in hand, I think. But maybe somebody wants to talk a little bit about the work around that cultural work and the change leaders and so on.
The clinical voice as well, if you would.
And the clinical voice, yeah.
Carol will want to offer a comment and perhaps an early reflection on that. Just very briefly, we developed a new values and behaviour framework. About 500 staff co-created that with us. Our values are compassion, openness and respect. That framework is being implemented because it's not going to be good enough to have a sign on the wall that says this is what our values are. they have to come through our policies, our processes, our everyday life. And that was the commitment we made. Integrated leadership development framework, 3 large-scale leadership conferences we've held with external support, nearly 100 culture change leaders from all walks of background and life, and we're aiming to get to at least 150. And then importantly, our Foundations for the Future programme really is the platform for the next phase of change in the organisation. And medical as well as wider clinical leadership is absolutely critical there. So
yeah, no, very happy to. I mean, I'm in my 8th week, so it's helped perhaps just to give a few reflections, and I can mainly reflect on medical as opposed to clinical. And of course, it is important for all clinicians to be working across, but particularly the triumvirate with operational colleagues as well. So I will reflect on medical, but that whole working relationship is so important. So for me, people have been very welcoming to me. They've committed to working to improve care. They're frustrated by circumstance in lots of situations, and they're somewhat sceptical about a new MD, medical director. Getting used to that. But there's a lot of innovation going on and lots of models which are evolving locally, and that approach of spreading across is something that we need to be working through in the regionalisation of services. And a lot of our services, as we've talked, to recognise the importance of thinking broader across the health board. Some are really nearly there and just need a little bit of support to be able to do it. And some within the challenge services, as we've discussed, needs more support to be able to get there. There's a lot of craving of autonomy and support to be able to get there. And I think that's something that we've discussed along the way.
Can I just ask what the obstacle is in that space?
So I think the obstacle in some respects is that really well-functioning triumvirate of where we are working together around service.
Doctor, nurse and manager.
Yes. And there's other clinicians as well, but it's that kind of doctor, nurse and manager working together around a process to be able to do that. And because we've then got 3 sites, so when you're then increasingly reliant on others across other sites, but we haven't got that formalisation of the way to be able to do that. For me, the medical leaders have, the tiers that I work with I've spent a lot of time working with them together, and they're really enjoying doing that. I think there are particular issues always for me about the clinical lead. So the first managerial leadership position for doctors, that first step from being a consultant in the tribe to being the kind of lead in that space, that's a really, really tricky manoeuvre to do, and is so critical for our leadership around that. We've got some programs in leadership going, but I think that one of the key things for me over this is clear job descriptions, clear roles and responsibilities, and support alongside to be able to do that. And there are some of our specialties where people are not as keen to take up that role as in others. And I think particularly in those and in some of our challenge services, it's really wrapping around those clinicians to be able to do it. We've already had conversations with Isabel as to whether we can do that in a collective way to support that leadership in action, which I think will be really important. But we are great at undergraduate education. Really good feedback, and our trainees are really often very keen to stay. So when we're talking about kind of culture, you will always get the areas where that hits headlines, but there's vast quantities who are doing a really good job and are working hard and are doing something really right if our trainees really want to stay in this area as well.
So how do you get that message out? Because part of the culture change is about highlighting some of that, isn't it? So it's an exemplar for other parts of the organisation. It's a motivation, there's a morale. What are you going to be doing to use that positive story, as it were, to help you with the changes you're trying to bring about?
Well, I think it's about being out and about, isn't it? And being and listening, which a number of us have done an awful lot around urgent and emergency care over the last few weeks. And I feel the real desire to make things better. But what we've got to do as an executive and organisation is show that we can do that. And one of the quality summits that we had last week, I said, right, just send me all the things that you feel need a decision. So we're kind of bringing it all out so that we can start to try and get that on the table and some confidence around that to be able to do it. You know, I'm optimistic around clinical service plans and taking elements forward. It's about horizontal, but it's also, I must say this, it's about vertical. We've got to be working into primary care and working collectively on that interface so that we can get our pathways correctly, because leadership in primary care is always more complicated to be able to do it. So whilst we're talking about, you know, regionalisation of secondary and acute service, we must also be talking about how we're joining back in, and it's that grid for me that's important.
Just quickly bring you in.
Okay, do you mind if I, do you mind if I push you a little, Clara? And I'm pushing you because actually quite a lot of what I'm hearing around the table is quite exciting. And I know you're a very experienced medical director, and and I've been a medical director myself in Wales, so I know how difficult getting your message out is. The health boards in Wales are huge, complex organisations. You've got 20,000 staff, off the top of my head. And with the best will in the world, you're not going to be able to get in front of all of them. But actually, you want every single one of those 20,000 staff to be working at the top of their game. And, I'm so excited about what we've talked about with Stand Up Now. I'm so excited about what you talked about with urology, with quality standards in ED. This is all exactly the stuff you need to be doing. How are you going to spread and scale it when you are constrained by this model of functioning as three economies in the north? Because that seems to me to be the thing to crack. How do you get your voice heard in a complex organisation that is used to being siloed?
So that, of course, is the challenge, James. Thank you. So
you're right.
So I cannot do this by myself. None of the clinical execs can do this by themselves. None of our executives can do it by themselves. We are reliant on models of distributed leadership and being really clear strategically where we're trying to be driven, and then supporting, particularly from a medical perspective. And I also think that's slightly different because we come into leadership late in careers, about supporting people, being clear what we expect them to be doing in roles, and then supporting them in that. But equally, having that ability for everybody to understand that bigger picture of driving it through, which comes back to, strategic aims, 10-year strategy, clinical service plan. What is my role within that? And then how do we, getting some of those really started to make some progress and some driving enthusiasm associated with it. And Paolo, is much more experienced in this than me, and may work to add, but it's that working with other colleagues to make sure it's that whole health board.
So I absolutely accept what you say, and I agree with you. And I'm just thinking what the board's role is here. So you've talked about autonomy. Your health board will only work if people have earned autonomy in the right areas of the organisation. But autonomy carries with it governance risks, because autonomy taken to the extreme is anarchy. And we are a highly regulated profession, quite rightly, within medicine. So what information does the board receive that assures it that as you loosen the central reins, which you have to do, your services remain safe?
So I think that when I talk about autonomy, what I'm talking about to some extent is people saying, give me the autonomy and hold me to account, is what they are saying. So they're not saying, let me do what I want. They're saying, let me do it within those pieces, and I will assure you. And I think that is an important distinction. I think from a patient safety point of view, there's been huge progress over the last couple of years of moving to a point with a very clear integrated concerns process, where if incidents occur or we get feedback from incidents from the medical examiner, from the coroner, from complaints, there's a daily huddle to pick those up. There's then a weekly executive oversight of rapid reviews. We then decide how to investigate that incident and take it forward.
And reported through committee, but
that's going to be thank you.
And then we do that. We then, of course, have to do the learning associated with that. all of that comes up through various groups into an executive policy group, into QSE, and up into board. The challenge, the next challenge for us associated with that is to take that next step of what are the outcomes that we want to focus on equally. So if we are looking at our audits, for instance, or our NICE standards or our mortality, what are the themes that are coming through, and where are it with that our national audits or our data show that we are outlining, and what is it that we are doing specifically about that, which comes back to the discussion about ED. So what are we doing in our time critical pathways for those who are coming in with an MI to make sure that they are having timely intervention, and how are we learning associated with that? And the policy management system that we've also got then helps to bring all of those together into that process.
Can I just come in?
Yeah.
Sorry, exactly. I just want to make 3 really quick points that were sort of like zooming out a bit to the big picture. And I think at the start we were saying, well, the board's been in place for 2.5 years, which is sort of true. But we've had really wholesale change in the executive in that time. And as you will see, I think some of our newer executive members have given very good account of themselves at this meeting, I personally think. But we've got some really great people, we've got a really strong team now. But it has taken a long time to get to that position. So having clear leadership, having united leadership, so the fact that Tamila and Claire are right from day one have been joined up, that's really important. The second point is that David said earlier, we didn't start from a clean sheet of paper. And one of the unfortunate things, in a way, it's a good thing. But one of the things I get, because I spend a lot of time going out and about the organisation, is people got so used to working in a dysfunctional whole organisation and the amount of flack that came to the organisation, some of it just justified, that they battened down the hatches. So teams concentrated on doing a good job as far as they could in their sort of little bit, and became quite impervious to messages from the top, because all the messages from the top were just bad or complicated, or to be honest, you put your head above the parapet, you got it shot off. So keep our heads down, get on with the job, often do a good job, but that makes it even more difficult when there is real change in the board to communicate that and to get people to open up those hatches to receive that message. And that's where the third point is then about the lack of clarity about reporting lines, which has been very, very evident. So people in quite senior roles, but out in the field, haven't known how to get in touch with the board because the organisation's not been clear. And that's where both the culture change work that's done by recruiting people from across the organisation at different levels to be advocates for cultural change, not just it all coming from the top is important, but also where the clarity of the operational model and foundation issue really is important. And if we can put in place a really, really effective and capable executive who are up for the challenge of improving the organisation, and they absolutely are, and combine that with a structure which allows people who are working at the coalface, we'll put it like that, to know who to talk to and how to get change effective, then I think we really will see a difference. And believe me, I think I can speak for the other independent members, it does feel a long time, and it does feel that we haven't seen change in the way that people out there notice. But we really do think that we're putting the ingredients together now that will deliver.
Okay, well, that's exactly what I want to come on to, because accepting the point which you make, and I completely agree, everybody in the room is new to the organisation, some are very new to the organisation, so that is absolutely understood. So looking forward from where we are today, I won't be sitting in this chair in a year's time, but whoever it is will want to be hearing from the organisation the work around clinical empowerment, the work around staff morale, the getting away from that culture of, as you put it, battening down the hatches, and just where people feel empowered and able to engage. What will you be able to say in 12 months' time are the tangible signs of progress of this strategy, both from a patient, the public point of view, and from a staff point of view? What will you want to see is the early but tangible fruits of what we're talking about today?
I think there are two ends to that, opposite ends in a way. One is where somebody anywhere in the organisation can bring forward something that's going to improve outcomes of patients, because that's their experience. They discovered something and they want to do something about it, and that does happen. The other is where people see there's something gone wrong and something that isn't right, and that people feel that they can speak out and can approach whoever in the organisation and express that. I think both those two ends of that spectrum say something about the organisation, where people firstly feel the enthusiasm and feel engaged that they can influence something in a positive way. But equally, if somebody sees something that's wrong, they're able to not just identify it, but speak out and know that they will be taken seriously and there will be action. In 12 months' time, I'm hoping that picture is one that someone will see.
And what will it be from a public point of view?
In a public, I'm in the
patient or member of the public.
Yes. When somebody next stops me on the streets of Dublin and I'm hoping they will be able to say that, do you know, I've been seen pretty quickly. I was waiting, but I've been seen pretty quickly, and I've had excellent treatment. And that happens at the moment, actually, but people do tell me I've been waiting 2.5 years for a hip replacement. And then they tell me after the 2.5 years, do you know what? It was absolutely brilliant. So I'm hoping now that people will say I was seen quickly and the experience was a good one. I'm also hoping that people will see that health is not about the hospital on the hill, but rather people will see that we're trying to drive ownership, public ownership of health and well-being, community ownership, where people can take responsibility and contribute to that positive end, but also that the way we deliver services is community-based in order to help improve those outcomes. So I'm hoping from the public perspective, they will see that shift, and any facilities that we are hoping to deliver will have that mirror rather than just a new building. It will be about delivery of services in a different way and engaging with community and citizen groups.
Okay, diolch yn fawr to that. We've got a few minutes for you to touch on anything which hasn't yet been covered in the agenda. If you want to put anything else on our radar, or if there's any element that you feel we haven't explored that you want a few minutes to raise, there's an opportunity for you to do that now.
Well, can I, in a way, repeat what I said at the outset and welcome the discussion? I think the way we were interactive is really good for us, because you were helping us focus on where we need to improve and shining a light. We welcome that, and we will take everything from today as a resource and in a positive way that will help us drive forward. I've been reflecting on a couple of things over recent days, and in many ways, what we have to do as a health board is pretty straightforward, actually. But it feels complicated often because of the machinery and the way we operate. So I think we've got a real opportunity to create something we can be proud of and something our population can be proud of. One thing we haven't mentioned today is the huge potential that exists because we are a university health board. We have 2 universities in our region, and there is huge potential, not just the medical school, but pharmacy, potentially dentistry as well. And the great asset we have in our communities. It is underused in terms of health, post-COVID in all our communities. In the community you're part of, the community I'm part of, there's huge activity. And health doesn't register much, and I can see potential for us to do much more in that space that will promote what I term as community ownership, health and well-being, and I think it can be an important factor. But I want to emphasize again, we appreciate the partnership working we have with yourselves, our government, and that our staff go the extra mile every day. It is a privilege to be part of a health board where we have people really serving the NHS in a hugely committed way, and the dedication is something that will help us get to where we need to be, and we should be really proud of us now.
Well, we'll all endorse that. Thank you everybody for your time today. As I mentioned at the start, the focus of the meeting is always on those areas where there is further, sometimes much further to go. There is less time to talk about the things which are working well and for which there's been progress, but I hope you felt there's been an opportunity for you to raise some of those areas as well, and they are there in the evidence paper. Obviously, there are a number of points today which we've committed that we'll continue to work on. Sometimes it's about support, but there's other elements about providing further information and assurance. So we will follow up on those outside the meeting. But thank you everybody for your time today. Diolch yn fawr iawn.
Yeah.